Hello, everyone. Welcome to the closing question and answer session of the FORCE conference. I'm Dr. Susan Domchek. I'm the director of the Vassar Center for BRCA at the University of Pennsylvania, and I'm thrilled to be here today. We're going to quickly introduce ourselves and then jump directly into questions. So Dr. Karen Hurley.
Hi, I'm a clinical psychologist by training. I'm at the Cleveland Clinic, and I've been specializing in this area for over 20 years.
Dr. Diljeet Singh. You're on mute.
Classic Zoom. I'm Diljeet Singh. I am an integrative gynecologic oncologist, and I've been fortunate enough to be connected to FORCE for a really long time. And currently I work for Mid-Atlantic Permanente Group in DC.
Great, and Dr. Matt Yurgelun.
I am Matt Yurgelun. I'm a GI medical oncologist at the Dana-Farber Cancer Institute in Boston. I see and treat people with a variety of GI cancers, and I also direct our Lynch Syndrome Center here at Dana-Farber.
So we're thrilled to be here, and we have a list of questions that were given in advance, but we welcome additional questions. I'm going to be keeping an eye on the question and answer function, which is where you should put those questions. To get started, we actually had a few different questions about COVID-19 vaccines, obviously very topical. And so the question is, should we, this community, be concerned about these vaccines because of the inherited mutations that they have? So Matt, we'll let you take that to start.
Sure. I think the short answer is that there's nothing about an inherited cancer risk mutation that really should cause any concern or any pause from a COVID-19 vaccine status. I mean, I'm recommending all of my Lynch patients, all of my BRCA patients, et cetera, get vaccinated. I think there's a bit of a misperception out there that, because, we think of these Lynch genes as being DNA repair genes, mismatch repair genes, and we talk so much about, DNA damage and DNA repair that, and people have heard a lot about how some of these newer COVID vaccines are involving mRNA, and is there something about the vaccines that actually becomes dangerous for people with inherited alterations? I think the short answer is no, that there's nothing about these vaccines that are damaging DNA or RNA. They're essentially just using the normal cell machinery to create immunity to the virus in a very different way. So I personally am strongly recommending that all of the patients I follow get vaccinated.
And Dr. Singh, just a quick comment on cancer patients and vaccines, because just to reiterate this point even more.
Absolutely. Same, patients in active treatment, we are very supportive. All of the research, even people sometimes are worried that the COVID vaccine will be less effective. And it seems that chemo is not that immunosuppressive. It's the people who have had transplants and are getting immunosuppressed by transplants that really seem to have less, although they still get value from it. And so absolutely encouraging people with cancer currently on treatment also to be vaccinated.
And just as you can see, we're pretty a unified front. We'll let Dr. Hurley off the hook for this one. But as a reminder, right now is that the people who are dying of COVID-19 right now are almost everyone is unvaccinated. Not everyone, but almost everyone. And that is true of hospitalizations as well. So we can't recommend it strongly enough. Dr. Hurley, you did have you feel free to jump in there.
Yeah, well, I wanted to point out that in psychology research, there's a pretty well-known phenomenon called the omission bias, which is given two different risk scenarios, people will choose something that's riskier, but that doesn't involve an action of their own. They don't want to be the cause of harm to themselves. And so a lot of vaccine behavior, even before our current situation of controversies, is driven by the fact that people will tolerate a higher risk of disease rather than being the author of a harm that they've introduced to themselves.
Right. This is always about, the idea of being proactive, but I hear you. So it brings up the next question, which is to Dr. Yurgelun. I have Lynch syndrome and just started aspirin therapy. How much should I take and how long should I take it? And I will say that Dr. Yurgelun did address some of this in his talk earlier today, so feel free to go to that recorded session. But you got a minute to answer this time.
Yeah, I think the short answer is It depends. If you're being a purist about it, the dose that was studied, the dose that was shown to have a powerful preventative impact at reducing colorectal cancer risk in Lynch syndrome was taking 600 milligrams a day for 2 years, or at least 2 years, I should say. That's a high dose of aspirin, especially by modern standards right now. And there is a study going on right now looking at different doses of aspirin, trying to see, can we get away with a lower dose and still get the same preventative effects? I don't know if we can, but I suspect we can. The approach that I've typically taken has basically been to try to understand that individual person's future risk of colorectal cancer. And there's a lot that goes into it. There's somebody's age, there's somebody's sex, there's the gene that we're talking about in Lynch syndrome, and there's also just how much colon they have or don't have. A lot of people with Lynch syndrome may have already had most of their large intestine removed if they had a prior cancer, and therefore their future risk of cancer may actually be rather low. So, my recommendations for people spans all the way from don't take aspirin at all, maybe because it's too risky for you given your own medical situation, or, that there's no benefit because you have no large intestine left, all the way up to people who I recommend take at least 325 milligrams a day, talking about whether or not it makes sense for them to even take a higher dose. So I don't think that there's a one size fits all answer, to be honest.
Yeah, and what you're going to hear a lot from us today is about risk benefit, individualized risk benefit. We're not trying to be hedgy. We're just, it's just the truth of the matter that everything in medicine is about individualized risk and benefit. Dr. Hurley, several questions about testing children for mutations in genes such as BRCA1 and BRCA2, and feels like we've been talking about this for a long time, but give us your thoughts.
Yes, I mean, it's, this question came up almost as soon as we started doing clinical genetic testing. So I think a couple of things. Number one, with kids, sometimes they can't really articulate a reason that they want testing. They say they just want to know, or there may be kind of an illusion that once they know that they'll feel somehow more in control. At least they can check that off. There was a scenario in the question list that we had about a 14-year-old who was already assuming that she was positive, right? And that her mom wanted her to get tested so that maybe she would test negative and she could stop worrying. Of course, in that situation, the opposite could happen, and with unknown results. But the thing is, if the child is already catastrophizing about what their test result is going to be, that habit of catastrophizing might then dictate their response. So then they might start thinking about, imagining, dire future scenarios, when in truth, we don't know what the science is going to be like in 5 or 10 years, because I know all of, the people here are just working as hard as they can to come up with better solutions to help mitigate risk. So the other thing is, and I talked about this in my session, I'm talking about talking with children, is that sometimes children will pick up a parent's anxiety, and it's actually the parent's anxiety that's driving a child's desire to be tested. And so these are complex family dynamics that ideally would be explored with some professional support.
It's that's so helpful. And I think that, from a medical perspective, right now, there are no medical interventions that we do in children if they have a gene mutation or they don't, for the conditions that we're talking about now, BRCA1 and BRCA2 and Lynch syndrome. It can be different with some other very rare genes. And I can assure you that if we ever found out that there would be something to do in childhood that would change what happened, we would change our guidelines because we hear you and we hear what you're saying. And I don't know, Dr. Yurgelun, did you want to say anything specific to Lynch on this topic?
I mean, I was just going to say it's a question that comes up a lot in our Lynch patients as well, for sure. I tend to share Dr. Hurley's theory that in some cases we're talking about more the parent's concern than the children's concern, or the children's concern is coming from the parent's concern. I completely agree that if we felt that there was something that was going to improve their health or help prevent cancer for them in their pediatric childhood, teenage years, then we would be recommending testing or at least having discussions about that. I think the other piece that comes up that we sometimes underplay, or that we sometimes at least fail to discuss, is that, from an insurance standpoint, we can be burning bridges sometimes, whether it's life insurance, long-term care insurance, et cetera. And that type of kind of pretest counseling, we go through plenty with unaffected adults who are maybe being looked at for inherited cancer risk. And, we want to make sure we're not burning any bridges for down the road before a child can really be a participant in that discussion themselves. I think the only last point I would make is that, just anecdotally, I've always gotten the sense that, at least in Lynch syndrome, the buy-in from the individual themselves, the teenager, the young adult, or the not so young adult, tends to be better if this is something that they kind of came at their own speed. If they were a kind of an active participant and saying, yep, I'm ready to get tested, I want to get tested, I know what I'm getting tested for, rather than something that was kind of given to them as a diagnosis without them being a part of the decision making. And at the end of the day, getting that information is only helpful if you're actually doing something with that information. So I guess that's my 3 cents.
Yeah, that's great point. We're going to shift gears somewhat, and Dr. Singh, we have a lot of different questions about timing of oophorectomy relevant to different genes. So I'll start off just with questions about, we'll start with sort of RAD51C and D. One of the questions was specifically someone who had been recommended to have oophorectomy at age 36 for RAD51C mutation. So can you give us an idea of why the different recommendations for different genes are at different times? You're on mute again, sorry.
No, I'm sorry. The question I read, and I thought it was great, and there were several, issues framed around it. So to answer, Susan, your question, the different genes are associated with a different risk at different age. Unfortunately, they're all ranges, and we still don't have really good, precise ways of trying to tell individual people, to be individualized in the way we prefer. Very specific data. We use general data, and then we use people's own family history of when did they have, for example, ovarian or fallopian tube cancer in their own family, if at all. And so that piece of things gets challenging. I do think the other part that gets really hard for women is that this issue of whether or not having your fallopian tubes and ovaries removed means you're going to be in menopause. And why I say it that way is because the issue of using hormone replacement therapy or estrogen replacement therapy continues to have some lack of clarity around it. And I say lack of clarity because I think we have a tendency to just recommend the same to everybody versus, for example, with a RAD51C, when the risk of breast cancer is not dramatically increased, that would be a more of a side issue, in which case somebody might say it's very reasonable to put you on hormone replacement therapy. And so being careful about that. So far, the best data suggests if someone has their tubes and ovaries removed for an inherited predisposition like this, that if it's done before the age of 45, that there's relative safety in general to getting hormone replacement therapy. And then there's all the complexities that come along with your individual personal history, your family history, your weight, your age, etc. The question, as I recall it, asked about salpingectomy. And that's the other tricky part, right? Is that, like, we don't even know for sure in BRCA mutations if salpingectomy is sufficient or necessarily offers a whole lot, given that even the trials that are being done now, we're recommending kind of when you get to the typical age that we still take out ovaries. And so I don't recommend people take out their fallopian tubes at this point, other than for contraception or if they were going to have it done anyway. And technically, probably at age 36, you could wait longer, but it'd be nice to talk through with your doctors why you want to wait longer, kind of how your aunt presented with her cancer. But it does seem like it's not until you get past 50 that with RAD51C that your risks go up considerably. And certainly by the time you get to age 80, where there's a 14% risk, we would have hoped to have made the decision prior to that.
Yeah, I think the points you're making are great, and it really is very gene dependent. You know, we know that BRCA1 and BRCA2 are not the same, that the recommendations for those genes have evolved over the time, where for BRCA1, we talk about a removal of the ovaries, between 35 and 40, and for BRCA2 between 40 and 45, and for RAD, 51C and D, current guidelines are 45 to 50. But they're not arbitrary. They're because we looked at the lifetime risk of developing ovarian cancer and the ages at which they generally occur. And we're trying to sort of hit that sweet spot of minimizing the harm by waiting as long as we can to take out the ovaries, but doing it before people are likely to develop their cancers. And so everyone will come at this with a different perspective of the risk benefit. Another question that's in the question and answer right now is someone who is a BRCA1 mutation carrier who wants to wait a little bit past 40. Well, these are individual decisions. And so we actually do have some pretty good data that I will sit there and, for instance, there are charts that kind of show decade specific risks. So people can kind of look and say, there are women who say my risk of developing ovarian cancer is less than 3% by age 40 as a BRCA1 carrier. I'll wait till 40. There's others who say I had a relative died of ovarian cancer. I do not want to wait. You can understand how different people can come to those to different decisions based on what they're bringing to the table. So that's extremely helpful. I'm going to go to the next question. I'm going to go back to Dr. Yurgelun again and talk a little bit about vaccines to prevent cancer. And do we still, if you ever see us not needing to do screening or preventive surgery, and I talked about vaccines too. So both of us have a similar sense of, wouldn't it be great if they worked? But let's talk about how much work we need to do before we give up screening.
I would love to be out of a job for sure. I think there's, as I spent a couple minutes talking about in the talk this morning, there's some really cool science and some really cool biology underneath the idea and the theory that you can use one's own immune system to help prevent cancers and Lynch syndrome. Certainly, with new immunotherapy treatments, we're leveraging that biology to treat active cancers and making some good headway there, although a lot of work to do. But I would emphasize, as Dr. Domchek alluded to, right now we've got a lot of really good ideas, a lot of really good science that's mostly happening in mice and test tubes and petri dishes. But we're really just starting to understand how are we even going to study this in people, let alone does it work, let alone is it safe? If it does work, how well does it work? So the exciting thing is that we're kind of at the cusp where some of these very early phase trials are going to start. But keep in mind that a lot of these trials are really just looking at the idea of how do you even do this? How do you do this safely? Can you do it safely? And then it's going to take some time before we start getting at the question of, do they work? And if they work, how do they work? How well do they work? And, and once we cross those bridges, then I think, that's when we theoretically start getting into the questions about, well, do we have something that's taking the place for what we're currently doing? But as exciting as it all is, I think we're still a ways away from being able to tell people that, with Lynch syndrome, that they can stop their colonoscopies, for example.
And I do think that there's a number of different things that are going to intersect at once, which is, different preventative opportunities in BRCA1. There's the denosumab trial, there's vaccine trials, there's the potential for other types of preventative. At the same time, we're hoping that we get better and better at early detection. If we get really good at early detection, then maybe we don't have to do preventative surgeries. We're not there yet. But so all of these different things, better early detection, better prevention. And then when do you stop doing these things that we know are invasive? That's tricky. That's one of my big challenges with salpingectomy, as Dr. Singh mentioned. How do I know it works? And I am a big believer in clinical trials. And yet any individual person sitting in front of me, I'm still recommending that they have their ovaries out, even though I'm a big believer in clinical trials. So we want it to work. We have to prove that it works before we back off from what we have in front of us. So tricky situation. Dr. Hurley, I have another one for you, which is a situation we deal with all the time. My father has advanced prostate cancer and had tumor testing that showed he might have a mutation that could be inherited. His oncologist recommended genetic testing, but he refused to have it done, even though it might help me. How do I talk to him about this?
Yeah, and it's a really tricky situation because parents typically feel guilty about, quote, passing on a mutation, although of course they wouldn't have, passed on if they had control over that. I think it goes double or triple for parents who are facing advanced or metastatic disease because they're thinking about, maybe in the front of their mind or in the back of their mind, what if I'm not there to help take care of them when they're facing, life issues, or when they're facing their choices about how to manage their risk. It's really, this is a time when parents want to know that their loved ones are going to be okay, right? So I think that an important area for research, we do not know enough about the emotional needs of the members of our community who have metastatic disease and what their needs are regarding genetic testing, how to approach them. I think that there's a huge opportunity to do more work there. In this situation, the relative can talk with a genetic counselor to brainstorm about different options. So for example, the father might be willing to donate blood that could be stored and tested at a future date. They could also, and here I'm talking slightly outside of my license, but to what extent would the tumor testing, if you put it side by side with the relatives' germline test results, does that aid interpretation in any way? It's not perfect or ideal, but better than nothing, right? And then the other thing is, rather than pushing on the father, trying to make him feel bad about not donating, is not giving a sample or getting tested, is to listen, right? Listen to what the concerns are.
Yeah, Go ahead.
I was just going to jump in and say, in a case like this where there's questions and where it feels like there's a relative who's maybe being perceived as a barrier to somebody getting their own testing, that individual themselves, in this case the child, can absolutely meet with a genetic counselor. There's nothing that says that their father has to be tested. Yes, in a perfect world it would be helpful to have that information, but there's a lot that a genetic counselor or genetic specialist can help that individual kind of parse through with the information that you already have.
It used to be in the old days that there was a real pressure to have the person with the cancer tested first, and yes, there are many reasons why that is kind of a preferred approach, but it's not the only approach that we can take these days. So don't hesitate to get your own testing, even if your relative will not do it, because we still can potentially get information that way. And also sometimes, if your testing is negative in that situation, it's easier to explain then to your dad why it's important, because then you can say, oh, my negative testing will mean more if you get your own. So and again, genetic counselors are really good at helping you figure out how to talk to your dad. But I do like Dr. Hurley's final comment. People with metastatic cancer have a lot on their minds, and sometimes this is just not the biggest thing on their minds. So that's helpful. Dr. Singh, the hysterectomy question is, all over the place. So for BRCA1, particularly mutation carriers, there's two different situations. One is a discussion of risks and benefits going into the initial surgery of having the ovaries out. But the second, and the specific question asked here, is someone's already had their ovaries and fallopian tubes out. Do you really go back in to take to do a hysterectomy at a later time? And what is the absolute risk of uterine cancer for a BRCA1 carrier? So that was like 5 questions, but I figure you can
It's
handle.
all good. No, it's the same. I see what you're saying, how you're framing. So I'm going to start with the easier one, which is somebody who's already had their fallopian tubes and ovaries removed and has BRCA1, where we do think there's an increase in the risk of endometrial cancer, thinking about 2 different kinds, the endometrioid one, which is the one that we consider curable because people often come in and they're having bleeding or spotting and stays in the uterus for a long time and is easier to pick up. And then there's also seems to be a slightly increased risk of serous cancers of the endometrium. And those are the ones that have more ovary and fallopian tube cancer behaviors. The absolute risk is very small, right? Although it might be 3 times the general population, we're still talking about risks of 1.1% for a serous cancer, and I think it's something like 3% for a standard endometrial cancer. So when people come to me with this conversation, again, I do what everybody's been talking about, which is look at the individual person and what are their risks of endometrial cancer in general. Are they overweight? Have they been on tamoxifen in the past? Do they have things that might increase their risk? Are they struggling with hormone replacement therapy and it's the progesterone that's giving them all these symptoms that they want to get rid of, and there might be some other benefit to remove the, and so weigh all those things. In general, I don't recommend an added hysterectomy once the other surgery is done, unless there's something else connected to that surgery that would help the person, which truthfully isn't that uncommon, that somebody has urinary incontinence or another symptom or something impacting their quality of life where it's not unreasonable then to consider it. But all of itself, just to reduce a 1 to 3% risk of something, I don't think makes sense. And the risks of surgery are about that same range, 1 to 5% for having a real complication related to a surgery.
And also, I want to say that I've looked at some of the quality of life data. It was a while ago, but it was for a gynecologic study where there are added quality of life issues when it's a total hysterectomy, removing the uterus as well. There's more chance, again, talking slightly outside my license, so please, you're bumping into more nerves, you're doing more stuff on the inside. And so that there, may be, consequences in terms, for example, of sexual functioning.
So most recent data does not suggest that a hysterectomy increases the risk of sexual dysfunction in somebody who has normal sexual function prior to the hysterectomy.
Yeah, this was older data, so I'm glad that you clarified that.
Yeah, I mean, it's kind of interesting how we did sexual functions sort of studies, very sort of, vaginal penile intercourse related, and how the thought process that the cervix had a major role in achieving orgasm for women, which since those very early thought processes has been sort of frequently and multiply debunked. But there are absolutely more surgical risks associated with a bigger surgery. And again, it also depends on kind of the setting of the hysterectomy. So when somebody has really large fibroids and that's the reason they're having a hysterectomy, obviously their risk of complications high. I want to refocus back to the question you started, Susan, though. How about hysterectomy when you're having your initial risk reducing surgery? And very different from when I started out talking about this, when we really, really discouraged hysterectomy. I think given the data that there might be this increase in serous carcinoma associated with it, and given the more and more we learn about estrogen and progesterone when they're used as hormone replacement therapy, I think that it's reasonable to talk with the surgeon you're meeting with about the risks and benefits of hysterectomy, and sort of staying in this space of there's lots of ways to go about this. So if somebody comes to me and, they have been going through, breast cancer therapy and their goal is getting out their tubes and ovaries and getting back to work and getting back to life as fast as possible, then we hold off on that. If somebody comes to me and they're saying, I'm not planning on going through cancer treatment again, I'm 36, I want to be able to take hormones, and I don't want it to be complicated. And in that setting, it might make sense that we can do estrogen replacement therapy alone, which has a lower long-term risk of breast cancer associated with it. And I think that's part of something that we haven't done well in women's healthcare, especially in the gynecology world of, we think one size fits all, and I think we think we're always right. And so having that kind of back and forth of what your life's been like, what your cycles have been like, what your experiences on hormones have been like, I think that, it's worth that. And the other piece I will say is we've gotten better at surgery too, right? Our technology, as we think about our improved laparoscopic techniques, our improved robotic laparoscopic techniques for people who need that complexity of surgery, we do take care of people better. And we have people who are in better shape when they come to surgery, and we have thought better and harder about helping people recover from surgery. Any of you guys who've gone through surgery have probably heard the ERAS, oh my God, I'm having word finding difficulties, but improved recovery after surgery studies.
Right.
And they all show that there's a whole bunch of things we can do to help people get well faster and to have fewer long-term complications and to have fewer quality of life implications. And same as the estrogen and the hormone replacement therapy, it is obviously complicated and obviously needs to be individualized, but I don't think the blanket answer is if you have BRCA, you can't have hormones because you might get breast cancer. I think that isn't logical, isn't supported by the data. And we're still a long ways from having really good data, right? It's kind of the best study we have on the risk of hormone replacement therapy comes from a study in Israel with good long-term follow-up, but with a very kind of genetically similar, genetics beyond BRCA, and racially similar group. And maybe it doesn't make sense to expand that to everybody.
Yeah.
So
I do think that as you're kind of alluding to, people also come into things with their own sense of sort of risk benefit, right? Which and also what they're willing to accept as risks. So the fact is that a hysterectomy is more surgery than having the ovaries and tubes out, and so some people are like, well, and if you've had progesterone as part of if you did not do well on birth control pills, and so progesterone was not a good fit for you, that's going to be another thing. If you've had 6 C-sections, I don't think any gynecological surgeon is rushing in to do a semi-elective hysterectomy because the surgery is going to be harder. So that's why it really is a more nuanced decision. I think that the take home though is there's never, in my mind, and you can correct me if in BRCA 1 and 2, we're not talking about Lynch syndrome, where hysterectomy is a key component of what you need to do. But for BRCA 1 and 2, hysterectomy should really be viewed as optional, not mandatory, and it needs to be discussed as part of your surgery with all these implications in mind. I want to knock off a couple of really quick ones, really. Dr. Yurgelun, do you think Cologuard will ever be approved for people with Lynch syndrome?
I think it would be approved if we had any data to say that it was useful in Lynch syndrome. The reality is we just don't have any data to say that it's anywhere near even equivalent to colonoscopies in Lynch syndrome. They're biologically different cancers than your more quote unquote run-of-the-mill colorectal cancers. So I tell my patients I don't feel comfortable with anything short of colonoscopies really for colorectal cancer prevention in Lynch syndrome.
I have a bunch of questions about this, and I want to hear from everybody because there's one about Lynch, there's one about BRCA 1 and 2, all strike the same thing, which is when are we going to have more individualized risk? And I wanted to say a word about guidelines. So when Matt and I are both medical oncologists, and when our institutions are very big on guideline concordant care and how often are we following guidelines. But for what it's worth, we're considered concordant if 85% of the time we're giving therapy as the guidelines recommend, because 15% of the time is nuanced. All this nuanced stuff we're getting into, 15% of the time we do things a little bit differently based on family and personal history. So when we're talking about guidelines, realize that we're not talking about there are situations where we go outside the guidelines because of specifics of personal and family history. But individualized risk, yes, in past conferences, polygenic risk scores have been discussed. I actually didn't watch every session this time, so I don't know if they were discussed again. These are out there, these polygenic risk scores, which are changes in other genes that each individual gene change only impacts the risk by the tiniest amount. But like in breast cancer, we know about 300 of them now. So if you have all 300 good ones versus 300 bad ones, it can impact risk. The challenge is that we don't really know how people use this information. So for instance, we have a study that we're doing with led by Memorial Sloan Kettering, looking at how women kind of incorporate polygenic risk scores in BRCA1 and 2 carriers. So we're still a little bit in early days yet about how to use that. But I'd love to hear from everybody. Karen, like how you think this really matters to people in terms of individualized risk.
Yeah, exactly. And, I've heard from several people today, both in side chats and, in the talks that I did, where people were expressing frustration about having to wait for the data. They need to make decisions, without the data, or they're hearing disagreements between experts on these nuances. And so, there is a certain element of, we're on the frontier of science. We're constantly pushing that frontier, but to live on that frontier is inherently stressful. People are haunted by the possibility that what if they make a decision and then 3 years later, a research study comes out that invalidates their decision, or that they didn't have to go there or sacrifice an organ. So I think that, that we want to acknowledge the subjective experience of trying to process this information. Sometimes we are all getting, excited about the data, and whereas people find it frustrating to, try to boil it down for what it means for them. The other thing is that I had my old gym teacher who also taught us our driving lessons. He would he would tell us the deers don't cross at the sign, which means that you can have you can have a marker about where the average risk starts to swing up, but there's still always going to be someone who falls outside of the guidelines. And once you've become that one person, that becomes very isolating, and then it's hard to trust the next set of data that's coming up, because you can think of exceptions, and there's nothing that we can do to really change that. But I think it's important to acknowledge that piece of the puzzle when we are sitting with people when they're working towards that individualized decision.
So part of our rapid fire component is, as someone rightly pointed out, we're talking a lot about surgery, and why aren't we talking more about early detection, particularly related to ovarian cancer? So I'm going rapid fire. Dr. Singh, I'm going to ask you to talk about early detection of ovarian cancer. And then Dr. Yurgelun, the question for you is, why can't we do endometrial biopsies during colonoscopies, given how painful they are? So Dr. Singh, you go first.
Question.
Really? You're going to make him answer that?
Yes, I am going to make him answer that question. But you got ovarian cancer screening, because that's an easy one.
So I'm going to take 2 seconds on the question that you guys were talking about. The issue with risk is, even if we learned every gene and we had million people data that we're following, that doesn't include environmental exposures, and we know they interact very intensively with all these genes, what your weight is, how you live, where you were born, what you eat, how many kids have you had from when it comes to breast and ovarian cancer. And so even if we get relatively precise genetic data, we're still not going to be able to give one person a very precise read. There will still be ranges and still be an individual risk pattern in there. Why haven't we figured out how to screen better for ovarian cancer? Partially because for a very long time, we had no idea what ovarian cancer was and where it started, right? As we figured out that it's actually starting out in the fallopian tube, suddenly it was like a light went off. Well, of course, doing ultrasounds of the ovaries didn't help us with that because we needed to look at the fallopian tube. And the other issue is the anatomy of the ovary and the pelvis. And it's the ovarian surface and the fallopian tube surface where those cells can shed even before they're big. And we are still not in the place we need to be in terms of being able to identify those molecular or cellular changes at a time that's meaningful yet to change things. That said, I think the preventive tools that we have, I fully, thoroughly advocate for them, right? Doing your 30 to 60 minutes of some kind of exercise 5 times a week, considering the option of oral contraception or oral contraceptives or aspirin or curcumin or whatever, being on a Mediterranean diet, et cetera, et cetera. So I think early detection, I'm curious and I'm invested in blood tests and then molecular tests. But I have a little more sort of energy and space in that prevention space that we haven't fully exploited all the ways that we can prevent cancer.
I also think there's a kind of a social factor. I've never ever seen a newspaper article that says brave woman faces her risk of breast cancer by choosing intensive surveillance. The features are always about the ones who choose surgery.
Yes, and it is always hard when I see that, and particularly it's because something like, I want to be alive for my children. Well, so do people who choose screening. So we have to be careful of our language because people make different choices that are all reasonable decisions. But Matt, you didn't get off the hook. Why don't we do endometrial biopsies at the same time as colonoscopies?
Yeah, no, fortunately, I'm glad I had that time to think of a bunch of answers, but they all felt like excuses rather than answers. It's a really good question. And I mean, it's something that institutionally we're looking at trying to do. I know that there are colleagues around the country that have been able to figure this out. I think a lot of it comes down to some of it's administrative red tape, just that there are certain procedures that can be done in certain parts of the hospital that can't be done in other parts of the hospital. There are different specialists who do a colonoscopy versus those who do endometrial biopsies. And if your doctors are anything like me, we don't exactly run on time. And so coordinating multiple schedules to do essentially 2 procedures simultaneously becomes a lot harder to do than it seems like it should. I think that there is a lot of interest in the community in figuring out how to better systematize this, but it's absolutely the type of thing that sounds easy to do. It sounds like it should be much more doable than it is. And, as somebody, as an oncologist myself who does neither procedure, I don't do colonoscopies, I don't do endometrial biopsies. You don't want me figuring out how to do any sort of procedure, to be honest with you. It is a source of frustration for sure. But I think a lot of it has to do with, just trying to coordinate one busy healthcare provider is difficult enough. Trying to coordinate 2 from different specialties who are used to working in different parts of the hospital typically. I think that's what it boils down to. But like I said, I had a hard time coming up with an answer that didn't feel like an excuse.
You did a reasonable job, all things considering. I'm gonna say that thank you ahead of time because I want to take questions till the very end, but they're going to cut us off at 4. So if they cut us off, I just want to say thank you both to the panelists and to everyone who's joined. But I'm going to keep going with questions. Questions about the new sort of liquid biopsy for early detection. I'm going to take this one first and just say, we all want them to work. No doubt, we want them to work. Some of the challenges are that if you actually look at the prospective data and you look at the people who kind of tested positive on these panels, about half, they couldn't find the cancer. And so, Dr. Hurley, you can comment on what that might mean to an individual to sort of test positive for cancer, but then not find it.
That's right. So that just starts the roller coaster of, intense ups and downs and feeling even more frustration about, what can be done, and the idea of having a cancer that you can't figure out how to treat because you don't know where it is or what its characteristics are. That's really terrifying.
Yeah, and that's only one part of it. And these tests are going to get better. So my take on this is they're going to get better. But what I've seen so far, I'm not ready. I'm not ready yet. I think there's challenges with them. And even in the prospective trial that was done, like half the cancers were like lymphomas and leukemias, where it's not even really clear what early detection means in those situations. So I think we just don't have, I mean, believe me, the minute we think that these tests are good enough, we will roll them out to you. I don't know if Matt or Diljeet, do you agree with that? Okay, cool. All right. So again, it's 4 o'clock. I think we're about to leave. So again, I wanted to thank the panelists for their time, and I wanted to thank all of the members of FORCE for coming. So thank you very much.